Good morning, everyone. Welcome to Medicine Grand Rounds. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose history, language, and culture continue to enrich our vibrant community. This morning, I'm very pleased to introduce Drs. Lindsay Bridgeland and Shannon Ruzycki, presenting Building Equity, Diversity, and Inclusion into Grants and Research. Dr. Lindsay Bridgeland is a general internist at the University of Alberta Hospital. She's the program director for the General Internal Medicine Subspecialty Residency Program. She has a keen interest in international health and equity, diversity, and inclusivity initiatives. She has had several opportunities to contribute to medical education overseas and to ensure these valuable experiences are available to residents and other trainees. And Dr. Shannon Ruzycki is a general internist and assistant professor in the Department of Medicine in the Cumming School of Medicine at the University of Calgary. She's the director of research for the Health Equity and Systems Transformation Portfolio in the Cumming School of Medicine and the vice chair of EDIA in the Department of Medicine. So please welcome Dr. Lindsay Bridgeland to start.
Good morning, everyone. You'll notice Dr. Ruzycki is not here yet. That's because she's very popular and was giving a talk in anesthesia. So I'm going to talk for the first few minutes and then Dr. Ruzycki will appear. So we've noticed that there's not enough time in the fall at the Department of Medicine State of Address to give out the updates. So we thought it would be good if I just gave a quick update on EDI/ACB before Dr. Ruzycki gives her talk. And here she is. So the first thing I wanted to talk about is that the U of A has taken the initiative to reframe equity, diversity, and inclusion. This happened quite suddenly on January 1st, 2025. The U of A has initiated a rebrand of EDI. They wanted to shift the focus of the why of EDI to the intended outcomes of EDI. So the new terminology is access, community, and belonging. Access is the intended goal of equity, which is to ensure fair access to all by dismantling barriers. Diversity is simply a descriptor of the diverse representation that reflects a range of perceptions, views, and lived experiences so that a community can form with a shared sense of purpose and connection. And belonging is the goal of the inclusive practices to create an environment in which everyone feels seen, valued, and supported. So I just wanted to emphasize the name has changed, but this important work is continuing. I did hear when this rebrand happened without a lot of context that U of A was getting rid of EDI, which is not the case, just reframing. So I took over in this role as director of ACB in about a year and a half ago. And since I didn't get to provide the update back in September, I'm providing it now. And at the time I took over about a year and a half ago, I had several objectives. One objective is and one of my main roles is to support Narman as the chair with anything related to any ACB issues. I also wanted to develop terms of reference for the ACB committee, so that has been completed. I've had visions of reviewing the faculty promotions process, and I've been involved with both the academic and the clinical evaluation committees, and that's still a work in progress. I wanted to provide and facilitate educational opportunities to members and leaders of the Department of Medicine with respect to EDI. I wanted to figure out, first and foremost, what the state of EDI was in the Department of Medicine. And then I also had this vision that I worked with Dr. Lada on to create a video for program directors to use to raise awareness of bias in the CARMS selection process. So I'm just going to do a brief update of some of the progress. So I wanted to first and foremost thank my wonderful committee, the ACB committee. You can see all the members of the committee who have been helping out and taking on various initiatives and leadership roles. So I'm going to mostly focus on education as what I've been working on. We had a multi-pronged approach to increasing awareness of EDI. So one of the things that I've personally been working on is with Dr. Joy, Malcolm, and Nkosi from across the country, we're developing a national EDI curriculum that we're going to offer to all residency programs in all departments of medicine across Canada to use if they wish in their academic half days, because a lot of program directors struggle to figure out how to incorporate it, and it's becoming, it's an important Royal College accreditation factor. And then for about the last year and a half, we've been writing monthly sound bites in the Pulse newsletter. You have to scroll a little bit down, but there's every month there's various topics that we pick, and then we write a short descriptor of just to help people, have that drip method of information coming through every month and give people some things to think about. I've also made an ACP webpage. It's on the Department of Medicine website. There's resources on it. There's lots of videos that I think that are really helpful. So if anyone's interested, you can go to the DOM website and then find it from there. And then I worked with Dr. Ruzycki on a precision, equity, and anti-racism toolkit. We presented this, or more correctly, Dr. Ruzycki presented it to the steering committee last May. And so the precision and equity and anti-racism toolkit was related to the survey that we had sent out to the DOM. So we sent it to all faculty members in the DOM. And then Dr. Ruzycki presented the results to the steering committee. And then we introduced this toolkit to support leaders' next steps in promoting and enhancing EDI within their sphere of influence. There was also an organizational and a leadership survey that we provided that could help leaders identify areas of their priority. So I know when we do surveys, a lot of people never hear the results. So I just wanted to very briefly let everybody know a few key things that we found in the survey. So these slides were made by Dr. Ruzycki. So we had 184 respondents, which was about a 30% response rate. As you can see, there were more cisgender women who responded. And then primarily white people responded, but then 26% Asian, 4% Black, 1% Indigenous, 1% Hispanic, and 5% Middle Eastern. And so I'm just going to focus on 4 questions. The first question that I wanted to show everyone the data for is that the question was, do you trust your section to be fair to all employees and students? And the short descriptor of this graph is if you see lots of green, that's good. Lots of red or orange, not so good. So racialized cisgender men did not feel that they trusted their section to support them. And there was a similar theme across all groups of women. So we thought this was concerning because this shows at least 25% of racialized cisgender men do not feel that their section would support them, or was fair. Then we asked, in my section, is harassment is not tolerated. And as you can see, a similar pattern, concerning pattern, especially with Asian cisgender men. We didn't have any data for the racialized cisgender women and gender diverse participants, but you can see that at least even white cisgender men were disagreeing with this statement. If I raised a concern about discrimination, I am confident that my section would do what was right. So there was a very concerning response here that racialized cisgender men strongly disagreed with this. Same with racialized cisgender women and Asian cisgender women. And again, the light orange color is also a concerning result that we would prefer that it was in the green area, or at least moving towards the yellow and then the green. And then the last question I just want to bring your attention to was the culture of my section is accepting of people with different ideas. So this question had a slightly more positive response. However, women in general did not feel as accepted, like that the culture is as accepting than men did overall. So I just wanted everyone to be aware that those were the results of the study, and then we presented it to the steering committee. We had applied for a grant to study this precision equity and anti-racism toolkit, but unfortunately we weren't awarded that grant. So the next thing I just wanted to mention is this Equity Quest video. Some of you might have seen it, especially if you're a program director or if you noticed it in the Pulse. So I worked with Dr. Tayseen Latta from the PGME, and we wanted to develop a video that any program director at the U of A could use to address bias, raise awareness of bias in the CARM selection process. So the PGME funded this. It's a professional video. The Learning and Design Studio helped us create it. And then last year, prior to the MSM match, I sent it out to all the DOM PDs, and then we subsequently distributed it to all of the PDs at the U of A for all the 62 CARMS programs. And then this video has also been requested by PDs from other institutions who heard about it, who wanted to use it. So all of this is, the link is on the EDI, or sorry, the ACB website. And the reason some of this, throughout this talk, I'm using the phrase EDI is because we're the only place using the ACB right now. And so it gets a little confusing. Like if I don't want to say I'm working on a national ACB curriculum, because nobody, even in my group, would know what that means. So future directions, we plan to continue with educational initiatives. We're hoping to work on some leadership development. We've started a study on bias against IMGs. We're in the very early phases of that, just building the survey. And then studying outcome measures, getting outcome measures both for the Equity Quest video, which we already have the data, and then hoping to get outcome measures with respect to this national EDI curriculum that our group is developing. And then we've just recently created a CARMS residency application file review working group as a subcommittee of the PGME EDI committee. So then we're going to be looking at the CARMS process as well. So that's the update from the ACB point of things. But now I will hand over to Dr. Ruzycki.
Thank you for having me. I was presenting to the Department of Anesthesia about perioperative glycemic management. So sorry for being late. So I drove up from Calgary. I was like, I'm going to get everything done. But for this talk, I want to discuss how to build EDI into your grant proposals and your research projects. I'm going to start by differentiating between biologic and social identities and demonstrate how misunderstanding these identities can lead to errors in your research. Use EDI literature reviews to identify new opportunities for your research projects, and apply EDI principles throughout a grant proposal rather than just as an afterthought or a separate section. So biologic identities are based on physiology. So an example would be like your age or the number of X chromosomes. Social identities come from social cultural norms. And so an example is your caste, or a categorization that has important meaning and health connotations in India, but is less emphasized in Canada. I want to deeply explore two types of EDI errors and how they can influence research. So first, the error that occurs when we imprecisely define or incorrectly collect biologic identities that are associated with a disease or an outcome. And second, the errors that occur when we use a social identity as the biologic mechanism of a disease or an outcome. And I'm going to demonstrate the imprecise or incomplete definitions of identity and how that can lead to errors using the MADE-IT2 randomized trial. So this looked at how implantable cardiac defibrillators, or ICDs, could reduce mortality in heart failure with reduced ejection fraction. And this was published in 2002. It's a landmark study, and it was a positive result. And this led to changes in guideline recommendations to consider ICD implantation for people with certain ejection fractions. And of note, of the original 1,200 participants, 85% were men, and this was mostly because they recruited through Veterans Affairs in the US, which is military-based hospitals. But about 20 years later, some cohort data began to emerge in multiple settings, multiple countries, that female patients may have greater harm and less benefit from ICD implantation. And this is seen in multiple settings, but despite this, the the American Heart Association and the Canadian Cardiovascular Society guidelines still don't consider sex or gender considerations when recommending whether or not to consider an ICD for your patient. And so there's a clear issue here with how inclusion or underrepresentation of women in the original studies may have led to harm when applying these results of the study to female participants. But I think it goes a little bit deeper in terms of this error. So in the study, we've identified a difference based on female or male sex in how ICDs lead to reduced mortality. But why would this be? So like, what would be the biologic mechanism of this association? So we presume, though we don't know because the authors didn't actually explicitly state this in the trial, but we assume that the investigators defined male or female based on the health records data, which is probably based on legal gender. Legal gender is the sex that's reported on like your driver's license and your birth certificate. And that's typically based on your sex assigned at birth. So the external genitals observed by a physician at the time of your birth. But like, how would your external genitals at birth influence this association? Like, there's no biologic plausibility that external genitalia would be related to a survival benefit with ICD. Like, it doesn't make sense. And so when we stop there, like, oh yeah, females do better, males do worse, we're missing something really important. And that's because in this association, sex is probably, sorry, my animation didn't translate over, but there's a little DNA in there. This association is probably a surrogate marker for something else. And so one of the major differences, obviously, between female and males is the number of X chromosomes. So could the number of X chromosomes explain why ICDs seem to work differently in males and females? And if so, how does the influence of intersex people or people with differences of sex development like Klinefelters or Turners influence this association? So we know that about 1 to 2% of the Canadian population either is intersex or has a difference of sex development. And if we're misclassifying 2% of this study population, how might that change an association? And what are we missing when we're not looking further? So perhaps more plausibly, is it a hormone effect that explains this difference? So we know that estrogens affect vascularity and vascular function. But again, we know that the estrogen to testosterone ratio isn't a dichotomous state, and it can vary across the lifespan for premenopausal or postmenopausal women or people who've gone through andropause. We know that there are a lot of medications like hormone replacement therapy or androgen deprivation therapy for cancers that may affect this. And so again, like, what are we missing if we're misclassifying people in this way? And then again, we know that body size, most females are smaller than most males, but are we missing something when we're implanting ICDs in different body sizes? And probably less relevant to the ICD study, but you can imagine how it would be relevant in pharmaceutical studies. What about body fat percentages or volumes of distribution that might vary based on people's body size, hormone, or by sex? And so in a lot of these studies and in the Made It 2 trial, we've dichotomized females and males, but we know that physically and biologically, there's a full spectrum here. And this spectrum is not perfect, and it also varies across the lifespan. And so when we don't recognize when we've used a surrogate marker like female or male sex for an outcome or association, I think we're missing some precision and we're missing something deeper that could help us make better recommendations. So when we do this, we're taking a continuous variable that could be parametric or bimodal or non-parametric in a population like body size or estrogen to testosterone ratio or number of X chromosomes. And we're just like cutting it in half, which makes sense on a population level, but on an individual patient level is not really that helpful. And we don't even know what we're dichotomizing. Like in the Made It 2 trial, what is the biologic reason? What is the mechanism of action there? And what are we missing by not investigating that further, by stopping at man, woman? And what does misclassification or confounding in this way do to our results? So if we're not separating out body size, are we missing positive effects for larger bodies or smaller bodies that we're just diluting out by not paying close attention to this? And so there are tons of opportunities just at the front to incorporate EDI into your research programs and increase the yield of your studies just by being more thoughtful about what like female, male sex is a surrogate marker for. And so to think of this another way, you wouldn't study a medication to improve pregnancy outcomes in people who didn't have uteruses because you're going to dilute your effect size. They were never going to have that outcome. And so are we missing important things by not being a little bit more granular? And so now I'm going to talk about how we can lead to errors in research by conflating social identities as the mechanism of biologic disease. And I'm going to talk about uterine fibroids for this, so a bit of a shift from the Department of Medicine, but you guys stay with me. So we've known for a long time that uterine fibroids are more common amongst Black women, and the fibroids that Black women have are more clinically severe and harder to treat than for women of other racialized groups. But again, I ask you, like, what is this mechanism? Like, why is this? Like, how does Black race modify this association? Like, what's going on here? And when we think about this, we really have to ask ourselves, what is Black race? Because race is not a biologic or physiologic phenomenon. It's a social identity that we assign to others based on their physical appearance. And we often assume that race implies a shared ancestry or a shared biology, but there is no Black gene or set of genes. You can't look at someone's genome and know what race they are or what their ancestry is. And Africa alone has 1.5 billion people. So it's like it just doesn't make sense for us to attribute a shared ancestry to an entire group of people that explains this association. This is a social identity. And so then what could the mechanism be? So I want to talk about phthalates, and they're estrogenetic chemicals that are found in many beauty products. And people who have fibroids tend to have higher urinary metabolites of phthalates. Phthalates are commonly found in high concentrations in hair straightening products, and hair straightening products are associated with greater bioavailability and systemic absorption of a lot of chemicals. And the reason for that is hair straightening products are very abrasive and they can cause chemical burns. In fact, in Egypt, just to get back to internal medicine, in Egypt, there was an outbreak of nephrolithiasis among women using hair straightening products because there were high oxalates in these hair straightening products. So they had all these like young women coming in with renal stones, and they traced it back to find out it was from exposure to hair straightening products. So there's good systemic absorption in these abrasive chemicals. Hair straightening products are more commonly used by Black women than by women of other racial identities, and they're associated with the development of fibroids. So when you have something that's associated with both an exposure and an outcome, we have to start thinking about, like, is this a confounder? And again, the follow-up question is why are Black women using more hair straightening products than women of other racialized groups? And it's because of hair racism. And so this is a specific type of discrimination against certain hair textures more commonly had by Black people. And it's not just a beauty standard. It's a major issue of discrimination. So Black women who have natural hair like afros or who use protective styles like locks or braids are often considered unprofessional or unhygienic. And people have been denied opportunities for jobs or sent home from schools for violating dress codes for having natural hairstyles. So it's really common. It really affects your outcomes. And so to protect themselves from this type of discrimination, Black women often straighten their hair to avoid discrimination and being denied these opportunities. And this is important because racism is a social issue, not a biologic issue. And social issues need social and policy solutions. So for example, the Crown Act is a piece of legislation in the United States that forbids employers from not hiring people because of their hairstyle. So you know hair discrimination must be bad if the United States is legislating that you are not allowed to do this. Like, it's egregious. Like, can you imagine they're like teenagers being sent home from school because of their hair? Like, it's silly. And then Further, why aren't we regulating the amount of these harmful chemicals in these beauty products? Why don't we have black box warnings on this? Why aren't we teaching this in medical school? And so these are social and policy decisions. If we focus on fibroids as a medical issue, a biologic issue, and we stop there, we are missing these important interventions and this important data. And so it's not Black race that is causing this association, it is racism. And despite this, even though, if we're all in a multiple choice test, we're all going to say race is a social phenomenon, not a biologic phenomenon, there's no Black race. In the discussion of the epidemiology study I started with, they say the main consistently identified risk factors for uterine fibroids include age, Black race, nulliparity, time since last birth, and premenopausal status. So positioning race in all of these biologic identities and not naming this as a social identity frames this as modifiable, and it repeats that sort of epistemic racism that Black bodies are different than white bodies and there's nothing we can do about fibroids. I'm going to move on to how to use an EDI literature review to identify new opportunities in your research, kind of keeping these foundational principles in mind. And so an EDI literature review for your current field of interest can help you focus a study on a population that has been underrepresented in previous studies. It can help you more precisely explore the associations between identity and outcomes or disease development that's been seen in other studies. And it can help you describe the experiences of participants from an underrepresented group. So I'm going to start with how to identify representation and underrepresentation. The easiest way to do this is to just peruse the table 1 demographics from the landmark studies in your fields. So not just looking at the identities of who is there and who is not there, but also thinking about how are these groups characterized. So for example, this is from the Essence trial, which is looking at semaglutide in metabolic associated steatohepatitis or MASH. And so they've just put female. So already you can see that they're using a binary classification of sex. They're not like differentiating intersex people or looking at a granular definition of sex based on like anatomy, genetics, or other things. They didn't look at gender or roles. They've grouped racialized people into these very broad categories. So even looking at that, it can start to make you think like, what else could I explore in my research? You can also just like ask Google Scholar. So if you type in underrepresentation and your field of interest, I think you'll get a lot of results that will outline this for you. So there's 2 ways to kind of identify a population of interest. When we talk about representation, we're talking about people who are not as recruited or involved in studies compared to a reference group, but the reference group can vary. So you can think about comparing who's participated in trials to the general population. So in that case, you would want to say, how does this population compare to the Canadian population, whether it be for sex or gender, race, ethnicity, or some other characteristic? You can look at population prevalence, so comparing the people who are present in studies to those who are most affected by a condition. So like, for example, in rheumatoid arthritis, we know women are most often diagnosed with rheumatoid arthritis, but perhaps in clinical trials are underrepresented. So if you have a trial that's 50% men and 50% women, but you're in a female preponderant disease, you might be seeing an opportunity there. Or you can design a study to correct historical underrepresentation. So not aiming for, 48% male, 48% female, 2% intersex or non-binary, but rather you could say, I'm going to study only female participants in ICD implantation in heart failure because women were so underrepresented in preceding studies. So you have a lot of options. When you're thinking about representation in your research, you do not need to perfectly represent every possible identity. You can use your EDI literature review to determine which population you want to focus on. And that might be because of the literature review. It might be because of historical underrepresentation. It might be that you have connection to a specific community. So you can choose one identity, but you do not need to have every participant in every one of your studies being perfectly balanced with respect to sex and gender, race, ethnicity, ability, and all other characteristics. You can just choose one. That's very reasonable. Yes.
Quick question.
Yes.
I actually love that approach. Concerned about the ability to publish,
Yeah.
because if you said, and I recruited only women with Parkinson's disease, I can just imagine what the editors would send back on first screen.
The question, just if you're on Zoom, was about whether or not your study will be publishable if you recruit just a targeted population. I think it's really important to position the reason that you did that in your study, obviously, and it is possible that some areas would say this isn't generalizable. It's possible. It's definitely a risk. And there's a lot of risks with focusing on diverse recruitment. Like, it's going to be more expensive. It will take you more time. These are big threats to existing recruitment for trials. And it also can be a strength of your research in answering a question that hasn't been asked before. And I have some examples to reassure you, but the reality is it's not simple and it's not easy. It's also not simple and not easy to get informed consent. Like, we would all be like doing a better job and recruiting faster if we didn't have to do that. It would be faster and less expensive to not have ethics review boards. And we have a moral and ethical obligation to do research that answers important questions in a way that is just and fair. And so balancing these tensions is hard. Like, I don't mean to be glib, like, it's not going to be easy to do these things. I have some quick tips on how to address representation in your grant proposals and in your research. This is not meant to be comprehensive, and I don't have time to talk about all of these things just because it's kind of where we are in this lecture. Like, we're not going to solve it all today. But some things that can be really helpful to include in your grant proposal that moves EDI and representation beyond just your little separate section at the end of your CIHR to be woven throughout is talking about how community can be involved throughout your research project. So if you want to focus on people with lower SES or people who are unhoused, are you engaging community organizations that work with those groups? Do you have team members from those groups on your team? And that gives you that legitimacy and helps you develop a project that will be useful. When you want to design your study, you can use some of that identity, those identity things that we talked about earlier on to help you increase the yield of a study, put an EDI lens on your study, and better answer these questions. So I think there's a lot of value in doing this. So if you did your EDI literature review and you found that in your field of interest, either the disease or the outcome or the response to a treatment varied by participant sex, asking yourself, like, what is the biologic mechanism of that? And how can I collect that data in my study? So if you think it's hormones, like, how can you differentiate premenopausal and postmenopausal women? How can you look at a medication history to do this? And you can think about body size. I think body size is really one of the easy low-hanging fruit of this exercise, because you're going to have a lot of people's body size metrics in your electronic health record. Like today, like, you don't need to go back for that. I am always getting calls from pharmacy about people's like body surface area. And I'm like, I don't know where you guys got that from, but yeah, make your adjustment. So it's there. And it's a really interesting way to think about differences in sex based on outcome pharmaceuticals. Gender is a really interesting one as well. Like, if you have a more caregiving role versus a breadwinning role, how does that influence your healing, or how does that influence your participation in exercise rehabilitation, etc.? So this is feasible. And these are examples from inflammatory bowel disease research, where investigators noted a difference between females and males in both the presentation and natural history of inflammatory bowel disease. And so investigators then looked at how things changed around the time of menopause for women with inflammatory bowel disease, how inflammatory bowel disease symptoms varied with the menstrual cycle, and lastly, how men on androgen deprivation therapy for prostate cancer experienced a change in their disease. So, like, these are very plausible, interesting questions. I think that these add to the yield of an existing study. Because if you're studying how things change over time, and then you just throw in like, hey, by the way, have you ever taken hormone replacement therapy? Suddenly you have an exploratory subgroup analysis that will explain something in the literature. And so this is a really great way, when you understand biologic and social identities, to look at these associations. For social identities like race or ethnicity, you really need to think, like, if I'm seeing a difference for my Indigenous patients, Black patients, whatever, what aspect of race, ethnicity, or ancestry is really explaining this? So for example, does age at immigration influence the development of a disease? Does greater identification with an ethnic diet or cultural practices predict the association? Are there differences in occupational exposures or other types of exposures like beauty products that might explain this association? And so getting into more detail about these things can be a simple add-on that provides a lot of really meaningful data and better explores this. I'm not going to spend as much time to describe how you can collect data on the experiences of people from underrepresented groups, because it often ends up being survey or qualitative study design. But just know that you can include a study within a study design. So if you're doing a larger study or a larger trial, looking at certain outcomes, adding on questionnaires about experiences of racism or discrimination or identification with your culture, like adding those questionnaires on with like your SFQ9 or whatever you're doing, can help you better understand a potential association of a social identity with a disease or outcome. So lastly, I'm going to demonstrate how to apply EDI principles throughout a grant proposal. And the simplest ways to start by doing this are to revise your grant proposal to use inclusive language. So that's person-first language, so person with diabetes rather than diabetic, and using gender-neutral language. So instead of saying both sexes, etc., using gender-neutral language. And I don't have time to go through all of those principles, but they are available. Consider your identity demographics with precision and collect appropriate data to really explore proposed associations. So this is the sex, gender, and identity factor considerations from a CIHR grant that I was a part of. And the investigator said this to me and they're like, hey, can you just like spruce this up a little bit? I was like, yeah, I would love to. So they say the condition affects both males and females, and data from a landmark trials have found that both experience higher risks of adverse postoperative outcomes. We aim to enroll a similar proportion of both sexes as in our other studies. We will assess for sex differences in patient enrollment and protocol compliance throughout the study. Condition affects those of all gender identities, including men, women, and gender diverse people. We will recruit all people regardless of their gender. They go on to say, previous studies have suggested that males may have a higher incidence of the condition. For the primary study outcomes, we will use chi-square tests to determine whether there is consistency of effect in the incidence of condition. To our knowledge, no studies have shown gender-based differences in adherence to the intervention. We do not anticipate any differences in follow-up rates. So the easiest thing to do to just boost the EDI of this is to get rid of the binary sex and gender dichotomy in the wording. If you are using language in your grant applications or research that implies a binary sex or gender, or you use incorrect terms to describe them, your reviewer is immediately going to know you're not going to do a great job on this. Like if I was reading this and I was like, both sexes, I'd be like, the team doesn't have the skills or the knowledge to do this well. So you can immediately use gender neutral language. You will do better. Instead of saying we're just going to dichotomize by sex and look at if there's a difference, try exploring the association of identity disease in a thoughtful way. And that comes from your EDI literature review. So for example, when I revised this, I said, the occurrence of this condition is similar for female and male patients. Female patients have lower incidence of the disease than males, though the mechanism for this is not known. There are several plausible mechanisms for the observed sex-based differences in the condition. Of these, variations in hormone status may be the most promising. Data is conflicting. Hormone replacement therapies for postmenopausal women are associated with greater risk of condition in some, but not all studies. I also suggest explicitly mentioning people who have been excluded from previous data. So the effect of hormone replacement therapy for trans and non-binary people is not well described, because you don't want to erase these groups just because there's no data. Testosterone replacement in hypogonadal men is associated with lower risk of condition, while other studies demonstrate higher bioavailable testosterone levels are associated with greater incidence of condition. So in the original proposal, they were like, oh, there's no gender-based differences. But remember that hormone replacement therapy for hypogonadal men is a gender-affirming therapy. And so hormone replacement therapies like this are speaking to gender. not just biology. So when we revised this, I suggested that we ask participants about their hormone status and gender identity at the time of inclusion into the study to do a hypothesis generating sex and gender-based analysis to guide future study. So I'm not saying we are going to answer this question. I'm saying people have seen a difference in the past. If we see this difference, we're going to explore by asking people if they're postmenopausal on hormone replacement or not. And then we can stratify it out and try to see a trend. It's not going to definitively answer the study, but this is a more thorough sex and gender-based analysis than just a chi-square test. So I'm hopeful that even though this is a short presentation and it can't be comprehensive in addressing all the concerns and like all the strategies for this, I'm hopeful that these tools can kind of start you on a way of better incorporating these kind of EDI principles. I think it improves the quality of your research. I think it can help clinicians be more precise in their recommendations when we see these associations. And I really think it's the right thing to do. And I think you can get more publications if you incorporate just these, like it's an all-around win. There's no cons. No, I'm just kidding. But if you have questions or comments, you can either email me or I invite you to ask them now. I can't see what time it is, but I'm hopeful we have enough time. I timed us out.
Thank you so much, Drs. Bridgeland and Ruzycki. Thank you. We have time for questions. Yeah, go ahead, Dr. Lynn.
So there's one group, of course, that is not mentioned here, and ageism.
Ageism is a huge problem.
A single permissible ism that we allow.
Yeah.
You mentioned nothing about how we purposefully might include older adults in our research who are underrepresented throughout. And we're, as geriatricians, extrapolating all the time, often unnecessarily. So why no mention of ageism? Because older adults in Alberta, I mentioned that as the first thing that's wrong with our health system.
In some of the research I've done with Dr. David Colister, who's in your department, we did a scan, a meta-epidemiologic study of all randomized trials that were performed in Canada. And we did find, as you can imagine, underrepresentation of older adults. A lot of studies and trials have eligibility criteria that put age restrictions around participation, and those age restrictions are not well justified, as you can imagine. So, just making a cutoff at 80 years of age to participate in a trial. We use age as a surrogate for capacity to consent, and we use age as a surrogate for frailty. In the same way we exclude like female mice in laboratory studies because it's just too hard to control for all those comorbidities. So from my perspective, reviewing your eligibility criteria for unintentional exclusion and justifying each of your eligibility criteria in your study and say like, why am I including this? Is my age cutoff based on comorbidities, or could I just rewrite that and say, we're not going to include people with multiple comorbidities for whatever reason? There's been a lot of really great work by some Canadian investigators about how to include people with impaired capacity in trials, particularly people with early cognitive impairment or dementia, because as this population grows, it's a big issue. I didn't include it in this presentation explicitly, not to be exclusive, but more because we had 30 minutes. But I could talk about ageism. Ageism is a huge problem in general internal medicine as well. We use it as a surrogate marker for a lot of things that maybe work on a population level, but on an individual level don't really make any sense. So I think for that, it comes a lot into that eligibility criteria.
Thank you. Any other questions in the room? Dr. Daniels?
It's kind of a longer one.
Okay. Yeah, I mean.
So two thoughts I have, and part of what it comes down to is the pragmatism piece. So let's talk about the 2% that are intersex. What my gut says I should do if I was writing a grant is to say we will collect the data so that we're not dichotomizing male and female. So I agree with your statement. Although again, you're asking people usually to self-identify.
Yeah.
That's your thing, unless it's a registry. We will look at the very small subgroup. We do not expect to find statistical findings, and we will likely focus our results on male and female.
Yeah.
Is that fair?
I think so. Oh, yeah, sorry. For the people online, speaking about when you have in particular intersex people or subpopulations that you think are going to be really small and you're not going to be able to do a statistical analysis on. When you're including those data, you're probably in your statistical plan going to say, like, we're not going to be able to run statistics if participant demographic groups are less than a certain number. What I suggest, and I think the value comes in, is if you still report that those people were included in your study, first you avoid erasure. So we know, like, for example, in some political climates, people are like, every biologist knows that sex is binary, and we reinforce that trope and cause social harm to intersex, non-binary, and trans people when we uphold that false dichotomy. But second, I think it facilitates meta-analysis. So if every study is reporting that subsection of people who are in a smaller demographic group, like intersex or trans or non-binary people, then when people are going through and reviewing the literature and we're combining those results on a bigger scale, we know that that data is sub-identified and we can combine it and look for differences. Then we can explore those differences. Like, are they hormone-based? Are they body size-based? And kind of get into the nitty-gritty of that. So while it might not, have a great p-value or whatever confidence interval for your statistical analysis in your study, it facilitates combining those groups and finding that answer. So I think it's important both to be just and morally right and to represent those populations and scientifically. Yes. Oh,
No, this is a longer one.
okay. Because that wasn't as long as you sold it. You sold it long.
That means I give you one job.
Cool.
Would you agree with the statement, I, as a 45-year-old South Asian male,
Mhm.
have a high risk of cardiovascular disease compared to an age match, physiologic match, BMI match, socioeconomic match, white male?
On a population level,
Yeah.
for the people on the Zoom, Dr. Daniel said, as a 45-year-old male, do I have a higher cardiovascular, South Asian male, I'm so sorry, South Asian male, have a higher cardiovascular risk than a BMI age matched, otherwise identical white male? On a population level, I say yes, on a population level. But what the mechanism isn't just because of your skin color. And when we stop there, I think we're missing important information. So, like, for example, if we think there's a genetic underpinning or an ancestral underpinning for an increased risk of cardiovascular disease in a South Asian man compared to a white or Northern European man, it might be worth our time then to say, what's your family history? If we care about genetics and ancestry and combined sort of biologic underpinning, maybe we find that a South Asian man with no family history of cardiovascular disease is more similar to a Northern European man. And that gets us closer. Or maybe I would say, were you born in Canada or did you come from a Southeast Asian country? And if so, what age did you come? Or I might give you a questionnaire and say, in your teenage years, how many nights a week did you eat South Asian food? And that gets us closer to that association. I think the problem comes when we stop and we say, you're South Asian, so-and-so is Northern European, and the difference is that your bodies are different, full stop, period, and we don't explore that further. Because I know that if I put your genes beside a white man's genes, I couldn't tell them apart. And not just me, scientists, geneticists, like obviously I can't tell them apart, but you know what I mean? And so I think we're missing something when we stop there, because I know your body is not inherently different because of your skin tone. So then what is it?
Can I just?
Yes, a
Um,
follow-up.
Absolutely, I'm thinking about my annual living talk with the Armed Force.
Yeah.
Right? I don't know how practical this is.
Mhm.
How many percent of people could actually tell you, oh, VJ ate South Asian food 5 times a week when he was ages 13,
Yeah.
whatever. So I'm just not sure how practical this would be. I know it's easy because I agree with you that there are differences, and that just because I'm Filipino doesn't mean I'll have fibroids because or we'll have fertility problems because most Filipinos do, or a lot of Filipinos do. But it's the practicality,
Yeah.
I think, that I'm concerned about.
So when I'm talking about like how much Southeast Asian food is,
Naturally,
oh,
repeat.
repeating the question, sorry. The question for the people on Zoom was, how practical is it to sort of differentiate, you know, how much Filipino food did you eat in your developmental years and how well people know their family histories? From a research perspective, when we're sorting out those associations, I think you can ask those questions on a questionnaire, knowing it's not going to be perfect, right? But if you ask me, like, how many nights a week did I eat pasta? I'm Italian. In my teenage years, I'd be like, all of them, like every single one. Like, I don't think I ever ate anything different. So you get like a general vibe, knowing that nothing is perfect when it's self-reported.
Italian is perfect.
Sorry, except for Italians, which are perfect. Sorry,
Every morning.
we're gonna live forever.
I'm perfect, I'm Italian.
Same, but clinically, and this comes up a lot too with lipids and with hypertension, is that we know that people from Western African countries have a higher incidence of hyperaldo states and respond better to spironolactone. And we know that on a population level. But when you're talking clinically and you're looking at the person in front of you, I think the real message is we need to phenotype you better. So for example, you know, I'd get an LP(a) and an LDL in you, and I would get one in a 45-year-old white man, because that gives me a biologic mechanism, a risk factor to know what to say to you about starting your statin, which you should, obviously. And if I'm talking about, you know, you have hypertension and it's resistant to many drugs, I should phenotype you, right? I should, you know, do your workup for hypoaldo. I should add spironolactone and see how you resolve. I shouldn't just say, well, you're white, so you don't have hyperaldo, or you're Black and you have family from West Africa, and so you are hyperaldo. You take the next step. And so it's not about, you know, being colorblind and saying, I don't see race or ancestry. It's about saying, but what's the real association and how can I actually investigate that in a way that makes sense? Or how do I sort that out in research instead of just stopping on these population level experiences when we treat humans? I think there might be a question on here that I didn't notice. Okay, do you mind if I'm just gonna answer? I forgot about the question and answer on the internet. I'll read the questions for you though. Oh yeah, you can't see them. Would you kindly comment on the CIHR sex and health pathway? Is it needed? I think that the system level CIHR incentives to further investigate this and to provide the extra money and incentive and grant funding to specifically say this is important is helpful. It's like, to your point about would a journal publish a study of Parkinson's disease in just females? If that journal had a special issue on sex and gender, I think highlighting these issues gives you an opportunity to say, oh yeah, I've got a niche interest. You have a journal that's going to promote this. So I think these system level incentives by journals and granting agencies are really important. South Asians are being recognized to have reduced normative BMIs. So sex, gender, ethnicity should be considered in BMI intersectionality. Okay, this is a really great point. So this gets to race correction. A lot of our normal curves are derived on white people, and they don't necessarily correlate with risk of disease in other groups. So BMI is a great example. We know that we adjust when we are estimating GFR, we take a creatinine and we adjust it for sex, binary sex, and that's meant to correct for musculature on a population level. But how does that work on an individual level? If you're a more muscular woman, are you being overestimated, underestimated? How does hormone replacement therapy work in that? As you get older, we assume you become more sarcopenic and we adjust the creatinine to eGFR equation for age. There's a lack of precision there. So race correction is a huge problem, and I did not touch on it, but when you are incorporating EDIA into your research, looking at all of your variables and saying, are these race corrected? Are these sex or gender corrected? Might be a nice way to do a sensitivity analysis. So if you have, for example, you're looking at BMI and outcomes, you might want to look at BMI and outcomes, and you're like categorizing people like obese, et cetera. You might want to look at a sensitivity analysis where you extend that for certain groups of people, because we know we have made this all up and we've used a lot of surrogate variables. So I don't have to talk about race correction, but there's a group in Toronto, who does a lot of work on race correction and how it can influence your research. I can't remember the name of them, but if you Google Toronto race correction, I think it will come up. Okay, so socioeconomic status has a big impact on health. Should that be a mandatory part of every grant application? And are people without housing included in large trials? So that's a great question. When we did our meta-epidemiologic study looking at eligibility criteria of Canadian trials, a lot of eligibility criteria implicitly include housing. So like, for example, access to a computer or ability to go to follow-up appointments or having a caregiver. And so that really restricts housing. A lot of, people will always say like the differences that we see for race or ability or poverty are all mediated by access to healthcare and socioeconomic status. I'm not convinced that that's true. I don't think we've well explored this. I don't know that it should be a mandatory part of every grant, but I think when you're going through those list of identities for your grant, I think it makes sense to include socioeconomic status maybe as a moderating variable in a lot of your grants, but you have to decide based on your EDI literature review, your field of study, what makes sense to include, knowing that you're not going to be able to include meaningfully everything. So I wouldn't say mandatory for every study, but like certainly like it's important. Okay, sorry.
It's really a comment, something I learned. We're doing a genetic study with Parkinson's,
Cool.
and when I approach people, they often say no, especially my racialized patients.
Yeah.
But what I say to them is, research is overrepresented by white college-educated males.
Yeah.
I would like beige and brown and black people to be seen in genetic studies. And then they say, yes, because they sort of feel it's a way to be seen by the medical establishment. So I think the way you approach people and to say what your intent is so important when you're asking these questions, because a lot of racialized people will not want their identity known because we feel it's an effort to exclude us.
Just to repeat that, it's a comment about how you approach people for participation in genetic studies, with the observation that a lot of racialized people do not initially want to participate in genetic studies until you kind of share the intent, which is to be like more diverse and inclusive, and to follow that up. So like, okay, when you're younger and you're sitting around the dining room table and the stories your family tell just become like truth. So like, we're Italian. So I was always taught that the Brazilian football team were like mean. They're the worst people in the world. France, they're all cheaters, all these things. You just believe it. I'm like, oh yeah, the, French football team, they cheat, like Brazil, they're mean, all these things. And they become the truth, these things that you believe in your family lore. For some racialized groups, their family lore, what they were taught around the table is that so-and-so was in a study and they killed him. And it's because it's true. Those things happened. People were enrolled in studies and they were not treated. They were not treated well. They were exploited. And the results of those studies did not benefit the groups that they were studied on. And so if you're sitting around the table and your grandma's just like, oh, your grandfather was killed by a doctor. Yeah, that's the story you hear, you're gonna believe it. Now that I'm older, I still believe that the Brazilian soccer team are dirty players, they're cheap. I don't even know if it's true. I don't think I've watched the Brazilian football team play a single match, but I know in my heart because my grandma told me. But like, so it's really important, those types of stories. And so a lot of ways to overcome that is, like you said, explaining the intent, but I think a lot of it comes from who does the recruiting. And I think we don't take this into account a lot of the time, but like if a white man is trying to recruit a racialized woman into a genetic study, that's going to feel differently than when you have community members recruiting other community members. So thinking about how much budget do you really have to hire someone from community, whether it be a religious community leader, or even just going to an association and saying like, hey, I'm looking for someone like this to co-recruit or to train to recruit. And that might, how would that affect your diversity? And how does recruiting people outside of the medical establishment look? So for example, instead of recruiting people at an appointment, what does it look like to recruit people in community associations, religious institutions, markets, festivals? Like, how does it feel different? And so thinking about that and being creative with that and engaging with community about that, I think will give you a lot of really good ideas. And I don't think it's that expensive. Maybe it is.
Well, thank you so much to Dr. Ruzycki and Dr. Bridgeland for a very thought-provoking medicine grand rounds. And I think you've given us lots of tools to think about as we move forward in our projects. Thank you.